recording again. And then I will let Alec go ahead and introduce our guests for this evening's continuing education, and we'll go from there. Thanks for joining us. Go ahead, Alec.
Hi everyone, thanks for joining. I'd like to introduce Dana Herrick. She is the owner of Imara Performance Physical Therapy, and she is here to talk about how the pelvic floor functions, specifically in runners. And Dana, if there's anything you'd like to add to that, feel free, but I'll kind of let you take it away.
Awesome. Thanks, Alec. Hi, I'm Dana. Thanks for everyone tuning in. Um, I was asked to do this about a month ago, and I'm excited to share my passion for runners and for pelvic health. I think it's a very unique combination of two of my big passions within the field of physical therapy is working with pelvic health, but then also working with runners. And there very much is an overlap that I hope whether you're an orthopedic clinician, whether you're a student, whoever you are on this course and on this call, that you get something to take away from this, whether you share the info with a loved one, you share it with a family member, that a lot of these things are common but not normal. So I want this to be formal, but also informal, as in, I don't want to go over time, so I'll try to keep it rolling. But if you have any questions, please feel free to throw them in the chat. And at the end of the talk, we can address those. So the topic tonight is rethinking the core in runners, looking at pelvic floor function, load management, and clinical decision making. Oops. Let's see if I can click it. Okay, there we go. So just a quick introduction about myself. I completed my undergraduate degree at Truman State University, went on to go to physical therapy school at Des Moines University, and took my first job with Rock Valley Physical Therapy here in the Des Moines Metro. I worked with them for 4 years, took a little hiatus to go chase some goals running professionally for 4 years out of state, moved back to Des Moines and worked for Rock Valley again for 5 years. Um, and in the midst of that, at the beginning of 2025, had the opportunity to go on a medical mission trip with a team of sports physicians, physical therapists, athletic trainers, and we worked with runners in E10 Kenya. And while I was there, I think my eyes were opened up to how much what we know as physical therapists goes much more beyond injuries and beyond just helping someone with their symptoms. And so coming back within the next few months, this last spring, I kind of got this itch to pursue running and pursue what I know as a clinician after my 13 to 14 years of being in the orthopedic field, to go a little deeper and to go into some deeper layers of what I'm passionate about. So then was born Imara Performance Physical Therapy, and I opened in October of this last fall, where I specialize in pelvic health with men, women, and all ages across the lifespan. But I also specialize with runners of every level, every age, but also athletes in general and the active population in general. I also really enjoy dry needling and was certified in that in the last year, something I never thought I would say that I enjoyed doing, even practicing on myself. Kind of along the lines of personal, I am a wife. I am a mom of two young girls. We have Murphy and Marnie, and then we have a golden doodle Javi. Like I said, I ran professionally for the Hanson's Brooks Distance Project from 2016 to 2020 in Michigan. We moved back to Iowa and we had Murphy in 2021, but I still continued competing and running at an elite level and still do, because that is still a joy and still a passion for me. And so I'm still doing it. I've also really enjoyed getting into coaching here in Norwalk, where we live, and volunteer coach with the cross country team and track team, and really have enjoyed getting to know those girls and just seeing the sport through their eyes, as well as having the background as a physical therapist. But I do enjoy having that coaching hat while I'm at practice, encouraging them to come see me at the clinic if needed. I also am actually starting a youth run club here in Norwalk this summer. So I am the co-owner of that and will be a coach of that for third through eighth graders. So I'm really excited to expose the community to the joy of running and just get a youth program started here in our community. So when you think about the professional and the personal that I just shared, my passions look a lot like the bullets you just saw. I'm very passionate about running, whether it's myself, whether it's other people. I love coaching and leading young women and athletes. I love providing education, whether it's like this or one-on-one patient care. As a runner myself, I love working with runners. As a mom myself, I love working with moms. I also like traveling and dancing. Sometimes my daughters like my dancing, and oftentimes they don't. And then I like to live by the mantra that to me, I run like life is long, but I remind myself to live like life is short. And in that context, uh, prioritizing the quality of relationships, the quality of the dark chocolate I eat, the coffee I drink, the brews I drink, and just in general, quality over quantity. So like I said, my professional and personal bullets do look a lot like my passion bullets. And I think I've learned in my 39 young years that I am my best self when I feel like I can use my gifts. And I know I can do that when those align. And when they don't align anymore, I need to reevaluate, realign, and refine. One of my biggest cheerleaders in life, one of my favorite people, told me that you will find what makes you happy and be good at doing it. God leads us down different roads to make us stronger, and we need to trust in his plan. And I think for me, whether that was personally or professionally in the last year, I grasped onto that and here I am. So today, getting into more the nuts and bolts of why we're here. Here are my objectives that you can read through that we'll touch on. But why does this matter? Why did I choose to talk about this? Besides the point that these are the populations and the people I work with. You know, runners often will come into your clinic if you are an orthopedic clinician or if you're a student, they will be coming into your clinic, depending on what piece of the field you're in. But they're going to walk in with pain, with performance plateaus, and they may have some leaking or some pelvic symptoms, and they're going to present differently. So in a traditional orthopedic model, we don't fully explain these cases, but when you think of pelvic health, it's often referred to as a specialty or a niche practice, and it is, but I would challenge that it's more of a missing variable, and it's a layer that should be a layer of the orthopedic eye, no matter who you're treating. It should always kind of be in the back of your brain, whether it's a question to ask, and we'll talk about that here in a little bit, normalizing some of these questions, and just remembering that the pelvis is the crossroads of the body. So thinking about the research and
I don't know if your slides are changing. It's still on like the first slide.
oh no, thanks for telling me that.
I was just
Um,
getting, it just says it's pause screen sharing on here.
hmm. Okay, let's see if we can.
It's always very collaborative finance. Station is with small firms, unless these can get more for.
Sometimes if you stop share and then just reshare, it will come back up. Sometimes it just does that.
Okay, I'll try that again.
It was
Sorry,
working.
guys.
I can verify. You did have it going.
Okay, do you see that? Okay, now can you guys see that?
There it's up.
Now
Oh
it's
gosh,
working.
I'm sorry. Not that
Oh,
you
you're
missed a whole
fine.
lot.
All good.
Thanks to the guy who raised his hand. He may or may not be related to me. Okay, so before we get into kind of the prevalence, just because I want to show off my cute daughters and things like that, we'll show a quick picture of that. But I am going to touch on the research of the prevalence of this before we get into objective number one, just because that's a huge piece to why I chose this, is getting information out of how prevalent this truly is with the pelvic health and athletes in general, and the amount of connection there is and the amount of impact sport has on the pelvic floor. All right, so objectives, why this matters. Like I said, pain, performance plateaus, a little bit of example leakage or pelvic symptoms that people may not connect to the fact that, yes, this is actually more pelvic floor related. All right. So, with our research, one of the first ones I want to highlight here is a systematic review that included 9 different studies that really just wanted to look at the impact sports and show, how much of this is actually showing in daily sport. So the pelvic floor symptoms, when we have anything on the slides of UI, is going to be urinary incontinence. So the nulliparous athletes are athletes who have not had children before. High impact sports also show significant increased pelvic floor symptoms in elite runners, recreational runners, men and women. And then it's also been shown in literature that pelvic floor muscle training with education regarding the anatomy and how the pelvic floor works is helpful and will aid in the prevention and management of these symptoms. I'm going to minimize something here real quick. Oh boy. Okay. Just so I can see all of my slide. All right. So when we think of, again, the next study, this specific research was actually put together to really showcase the prevalence in order to develop a screening tool. So I will touch on the screening tool later, but in this specific article, the International Olympic Committee, FIFA, World Athletics, rugby in England and around the world have really found that it's becoming, pelvic health is growing in the literature, but it's also recognized as a clinically relevant health problem that are truly affecting our athletes across the world. So when you think of the pathophysiology, it's very complex, it's very multifactorial. The symptoms are usually a combination of predisposing factors versus just one single case. And I'm sure you've said those words to any patient of yours that have come into the orthopedic clinic, that it's not usually just one specific thing. I mean, unless it's a true impact injury or surgery. But if it's something of a nagging injury that has come on, I always like to use the phrase, it's multiple layers, it's multifactorial. And the pelvic health continues to be overlooked and underestimated in our standard practice. This study also wanted to highlight that females have 3 times the risk of urinary incontinence compared to males. Athletes have a higher pelvic floor dysfunction, or PFD, prevalence than non-athletes. And then up to 80% of female athletes have experienced a form of pelvic floor dysfunction, which to me is wild. And I cannot believe we don't emphasize this more and shout this out more, that, urinary incontinence with those high impact, high intensity sports, 80% is a pretty darn high number. This study also looked at the impact on the body, and you look at the amount of force attenuation, the stress on the pelvic floor muscles, the influence that the pelvic floor muscle fatigue sets in from the impact, and then that continuous abdominal wall contraction, or some athletes may or may call it bracing, where they're tight and they're holding that contraction. That's obviously going to increase intra-abdominal pressure, which we will get into later as well, and how much that can be a cause and be a major impact on the pelvic floor. And then lastly, in this study, they also found that relative energy deficiency in sport, or REDS, that urinary incontinence is actually an indicator or a potential indicator of REDS in athletes, according to the International Olympic Committee. If you are not aware of what RED-S is, I highly encourage you to do a little bit of education for yourself for the sake of your patients. It is very common in boys, girls, men, and women, where essentially we're at a low energy availability. And again, if the urinary incontinence can be an indicator of REDS, all the more reason to go a little bit deeper with some of those subjective questions with your patients. Urinary incontinence in adolescent females can range anywhere from 18 to 80%, with that average being closer to 50. In this study, elite athletes who experience urinary incontinence early in their career were then more likely to report issues later in their life. Urinary and incontinence and urinary urge symptoms were also found to be 19% of a male track club in Spain. So again, just touching on some of the prevalence here. But then when we look at the impact of pelvic floor dysfunction and those symptoms, Females with pelvic floor dysfunction reported a decreased ability to engage in their sport. So this is going to affect, obviously, they reduce their intensity of how hard they were going. They reduce their frequency. Maybe they weren't running as many miles if they were a runner. And then it altered their more mode of involvement or movement and developed what we commonly see in orthopedic conditions and settings of compensation and compensatory patterns. So the negative effect on performance is often from that fear, let's say, of that visible leaking, or they're going to have loss of concentration. It's going to be emotional. It's going to be embarrassing, concerning. They're going to develop a little more anxiety. So the research continues to show that neglecting this aspect of health can lead to worsening symptoms, then also early retirement from the sport. And I think if there's anything of my entire presentation, when we think of the research and the prevalence of this, that bullet right there should set off a little bit of a light bulb. And maybe that's me because I'm a mom of young girls. Maybe that's me because I'm a coach. But that's, to me, is a marker that we as clinicians, if we can have any role in reversing that, should be a part of that in order to keep these girls in sports. Girls are already choosing to leave sport early on, as the research shows. And so if we as PTs can help that, why not? And then again, also just as important, a majority of these athletes don't share these symptoms with anyone, sometimes because they're too scared, but honestly, a lot of times because they don't realize it's not normal. So again, as clinicians, we have a platform here, and I think if we don't use that, we're doing a disservice to our patients. So when we think of a typical case, you have a female runner that comes in, she's not had any children, complaining of one-sided unilateral hip, maybe some low back pain. Her symptoms get worse when she runs hills, when she runs longer. From your, quick screens or manual muscle testing, she's got decent core strength from what you assess. And over the time and course of her rehab, she really has had minimal change. So kind of think in your brain, okay, well, what are we missing? Just a quick snippet here of a visual on the pelvic floor. Obviously, this is a female image here with the bladder, the uterus, and the rectum. So the pelvic floor already, just naturally, whether you're sitting, standing, takes a lot of load when you think of those structures. So as we want to describe objective one, the role of that pelvic floor in that core pressure management, we can think of it like a canister. So you have your diaphragm on top, you have your transverse abdominal, your deepest core muscle, in the front and wrapping around, almost like that corset muscle. Your multifidi are the deep spinal stabilizers between the spine, that's along the back. And then you have your pelvic floor muscles, just as it's called, along the floor. When we think of the core as a canister, we've got that transverse abdominals being the lowest, or I'm sorry, the deepest, internal and external obliques coming on the outsides, and then that rectus abdominal, not that you can see my hands here, but rectus abdominal across the front for those washboard abs. You have your multifidi again on the back, but when we think of that pelvic floor, a lot of the pelvic health world describes it as a hammock. I challenge that to say that it is much more than a hammock. It is a dynamic structure, and it's more of a dome. It responds to every breath, every cough, every movement we do, men and women, not only supporting those organs we just showed, but it's also supporting the entire pelvis and the spine in real time, no matter what you're doing, male or female. So to me, it's not passive, it's very powerful. So as a pressure system, then, when we think of the core canister, we want to imagine when we expand that canister, that is what we are going to do when we inhale versus when we exhale, we're going to deflate. So I always think of I might flip forward here for a second. I can find it. I always think of these therapy balls and I try to explain it to my patients and I never know what they're called. And I believe they're called expandable balls. But think of when you inhale, that is what we want the ribs to do. That is what we want your lungs to do. And everything's expanding, right? So when you exhale, it's going to go back in or deflate. So when you think of running, what happens when we run? Running generates repetitive high magnitude pressure, and we need that fluidity of that expandable ball, not rigidity. So that pelvic floor, again, not just a hammock, it honestly is more like a trampoline. It needs to absorb and it needs to be coordinated with time and needs to be able to transmit that load, not just hold. I mean, if you get on a trampoline that's brand new and those springs have not even gotten stretched out, that is not a very fun trampoline. We need to absorb, but also recoil. So a lot of times leakage and pain often reflects a load mismatch, not necessarily weakness. So many men and women assume, and unfortunately a lot of providers assume, when they hear that their patient has issues with pelvic health and leaking, the answer is often go do Kegels. And I am telling you right now, run to another provider if that is the only thing told to you, or if that is what you have heard. Please educate your patient that more often than not, because of this load mismatch, it's actually excessive tension. And again, going back to that trampoline analogy, too much tension, that pelvic floor ain't going to do what she's supposed to do if it can't move and absorb that load. So the intra-abdominal pressure then is necessary for sport and necessary for performance, but we are going to see problems when the timing is poor and that load exceeds that tissue capacity and causing that tension. And over time, the pelvic floor is going to fatigue out. So again, going back to that case of that runner, she mentioned hills, she mentioned long runs. Well, think of the load when she's running hills and more so downhill, that's a lot of excessive load. Think of the long run. That's a lot of steps. That's a lot of repetitive pounding. That pelvic floor, even if it's slightly letting go, is going to fatigue over time. And we're going to develop some issues with increased abdominal pressure. We can also talk about, in general, breath holding. So then I think of like lifters, or I think of some other sports where it's very common for people to hold their breath, and that's going to increase pelvic stress. We also hold our breath when we're stressed. I can't tell you how many patients where I'm teaching them how to do a simple supine exercise, and they're focused so hard and they're not breathing, and their face turns red and their lips get pursed. And the first thing I say is breathe. So that is a key point here that we'll get into here in a second. So along with your breathing, we need good rib mobility. So again, go back to that expandable therapy ball. Poor rib mobility is going to alter the pressure distribution. If we can't move those ribs, that diaphragm is not going to move. That intra-abdominal pressure is not going to decrease. So endurance running magnifies any little inefficiency. And that's what I commonly will tell any patient of mine. And this is where the orthopedic and the pelvic health crossover is more similar than you would think. When you think of someone coming in with any compensatory pattern injury, shoulder, hip, anything, it's those repetitive movements, those cumulative movements from the slightest inefficiency of weakness, tension, or lack of strength that is going to magnify over time. So I like this visual for the diaphragm anatomy photo here for a couple reasons. See that it's that dome-shaped muscle. When it contracts, it actually descends. So when it descends, its connection with the pelvic floor allows and encourages that pelvic floor also to descend. I'm not sure if any of you have the view of me right now, but I do a lot of hand motions. So if you don't have me on a visual, maybe get me up in the corner. But that diaphragm allows that pelvic floor to relax and descend, and it's very much they're a team. I also like this image because you can see how the diaphragm connects on the front of the spine, how closely it connects through that iridescent image of those hip flexors along the spine, which would be your psoas, and your iliacus along the inside of the ilium, the pelvis. The diaphragm is a very powerful muscle that if you aren't at least educating your patient on, no matter what you're seeing them for, you're doing them a disservice. And it is often one of my first exercises I teach my patients. Visit one is how to diaphragm breathe. So we'll get to that again here in a second. But going back to the running and the amount of force running is putting on our bodies, 5 to 8 times our body weight. every stride. Think how many strides and steps you take when you go out for a 3-mile run. The pelvic floor manages that repetitive impact and pressure, but it can only manage it so long if we've got that new trampoline and we're constantly impacting load on it. A couple of the literature findings that I have cited at the end in my references kind of sum up some nice things here, where the running definitely does create a transient strain on the passive pelvic floor, even when its contractile function doesn't actually change. So a couple of the studies that I reference, they looked at women before and after a half marathon, and they didn't necessarily have decreased strength, but they had change in the amount of repetitions they could do, the amount of endurance. And it definitely is something that, whether you're running a half marathon or a shorter run, it's going to affect the strain of the pelvic floor. We want to think of this as a load to capacity framework, like we already talked about, how much load versus how much can the pelvic floor take. The increased pelvic floor activity with speed and fatigue. So think endurance runners, and I'm sorry, the endurance of the pelvic floor. So if you're going quite fast, it's definitely gonna punk out on you. Pressure management does not mean to brace harder, and we're gonna get into that here in a second on managing that. Altered activation patterns in symptomatic runners, we know that they are going to change their movement patterns, and then they're going to develop compensatory patterns, and then they're going to be in your office for something that may not present, like pelvic floor. So applying the breathing and abdominal strategies to improve the tissue tolerance is where we get to apply more clinically here. So when we go back to that first exercise, I often prescribe to my patients and really emphasize is the true diaphragm breathing. So with inhalation, I often have my patients lying down, hook lying, knees bent up, and I like to do tactile cues myself, and then I like to teach them to do that on themselves so that they can replicate it at home. I like to have my hands on lower ribs, and I like to really emphasize that visual of those ribs being like bucket handles. And when you inhale, when you expand, remember that therapy ball expansion, we feel those ribs move out like bucket handles. And then the pelvic floor, as we translate everything down in the pelvic floor, we want to give that visual of maybe that pelvic floor being an elevator. And remember, the diaphragm descends as it contracts. The pelvic floor then descends. Therefore, that elevator goes down to the basement. I like to give that kind of that cue. I also like to give a nice little verbal cue for the pelvic floor. We don't want to go full on Valsalva maneuver and push, but there is a little bit of that feeling of push or pressure. So I like to utilize the what would you do if you were trying to push out a soft fart verbal cue. That usually gets people laughing, but it often works. But I will say it has to start with the diaphragm. It has to start with that lower rib cage movement. So again, coming back to our therapy ball, with the good expansion, kind of a visualize the ribs on this one and the recoil of the ribs, because again, that diaphragm descends. So then when we think exhalation, everything's going to recoil. So the diaphragm muscle relaxes. It's actually rising up where it normally sits. The lower ribs recoil. And again, that tactile cue I like to have on patients' lower ribs, I might kind of give them a little bit of pressure. The other cue, tactile wise for them at home, I like to have them put their hands on those lower ribs and get the thumbs in the back. And I would tell them to breathe into their thumbs. I also like to encourage breathing into the lats if they're a little bit more aware of anatomy, and on the inhale, and that actually helps get that expansion. Now, with the exhalation on the pelvic floor, if we're activating that pelvic floor, we're going to imagine that pelvic floor is that elevator coming back up. So again, that diaphragm relaxes, pelvic floor comes up. And if you are wanting more of that contraction or Kegel, you're going to pull that elevator up to level 1 or 2. If we're just exhaling, not contracting, not trying to engage lower abdominal, that thing's just going to lobby. But again, if we're contracting, we're going to pull up to level 1 or 2. And then I like to give the visual, verbal cue of you got that pair of pants that are just a little too tight. And so you lie down, you zip them up, and then you get the button. The zipper is your pelvic floor. You got to pull that up, and then you draw that lower abdominal in for the button. A lot of times, if I have pregnant or postpartum women, hugging the baby is a very good transverse abdominal cue because the transverse abdominal, it's like a not 100% effort muscle. I like to say it's more of a 50% effort muscle. If you pull that Kegel up, gently draw that in, and then you take it one step further and really tighten, you're going to pull in iliacus, you're going to pull in a little bit of rectus. So we really don't want to overdrive when we're trying to truly engage that Kegel with that transverse abdominal. So when I teach this, we start in hook line, lying down, but then we progress. And we eventually get up into loading, and then we get into functional exercises and then sport specific exercises. So it requires a lot of coordination. And that's where I really emphasize if we can't get this bread and butter of true diaphragm breathing with the pelvic floor coordination, then we're kind of missing the whole boat here. I like this visual, and hopefully it's working for you guys where it's moving. So as we exhale, you see that diaphragm come up, pelvic floor go up, inhale, everything descends. It can be a little bit confusing because when you inhale right here, everything's descending, but remember those ribs are getting bigger. So the bone structure is expanding, but the tissue, the muscles are going down with inhale. All right, so what are some of the contributors to pelvic floor symptoms? Again, it is not often due to the lack of strength. With these symptoms that you're going to see with a lot of our active population and runners and athletes, timing with our breathing, are they breathing? Or often they're holding their breath. Coordination, what we just talked about, the inhalation, exhalation with that pelvic floor movement, and then general endurance or fatigue of the pelvic floor, increase load or volume. So think, did your runner, increase their mileage as they're starting to do this marathon training? Or I have a male patient right now who over the summer, he threw on 40 pounds for high school football season. And now he's trying to deal with getting back into track season and groin tension, a lot of hip tension because of that change of weight. And we just have to retrain that body. How do we take on that load? And even in the pelvic floor as a high school boy. Running mechanics very much can be contributors. And then life factors. So again, is your patient postpartum? I always like to say once postpartum, always postpartum. I don't care if she's 3 months postpartum. I don't care if she's 30. Well, I don't care if she's 10 years postpartum. If she is having symptoms, you have to at least acknowledge this. Hormone changes, whether they're perimenopause, menopause as a female, were they sick recently? Think again, the intra-abdominal pressure of coughing consistently and chronically, throwing up. I mean, that is all so much pressure into those lower or into the pelvic floor. Does your patient have GI issues that they haven't shared and have you not asked, and have constipation that you're not aware of? And then lifting habits. And I'm not talking, oh, my patient's not a weightlifter, so I didn't really address that. Okay, well, does she have or he have a toddler at home? So it's like, okay, let's grab a 20-pound dumbbell. Show me how you lift that if that were your kid at home. And a lot of these things are going to influence and contribute to these pelvic floor symptoms. So many runners are strong, but they are not coordinated or layered in the way we need them to be. So when we think of clinically applying this, pelvic symptoms can be far more than that leakage. So again, this long, nice laundry list here of things that aren't always going to scream, let's check in on pelvic health and ask you some of these questions, but it's definitely a reason to dive deeper with those questions or objective measures. All right, so now how do we differentiate between strength, coordination, and some of those endurance or load impairments? So with strength, we're talking that max force. So don't get afraid when it's like, oh, was there a strong squeeze? Clearly, to truly test the pelvic floor, you're going to want to call in your pelvic health friend and colleague, if available, to at least give you a little insight on an internal evaluation. Examples of someone who is dealing with a true strength issue are likely going to have a little more of that true like loss of bladder control. Or honestly, it could just present more like compensation patterns. I always like to say if you're thinking of the pelvic floor as that dynamic, very powerful dome of a hammock, it's attached to two tree trunks, okay? And if we don't have stability in those two tree trunks, aka your hips, then that dome is gonna tighten to stabilize the pelvis. Well, if that tightens and those hip muscles aren't already strong, a very common example I see is the piriformis, is a very common compensatory muscle in a lot of my runners that fires and overfires because of lack of glute strength. So it's all combined, and it's all a reason to call in a pelvic health therapist if warranted for that true strength assessment. But from a coordination and timing standpoint, you can kind of think, okay, can they do the breath coordination we talked about in those functional movements, even going from a sit to stand? Can they actually inhale as they sit, expand everything, exhale, zip up that zipper, tighten that button, and stand as they go against gravity through a coordinated movement? Trunk strategy. Are they very in any of the movements you're looking at and watching? What's their trunk strategy? So again, an example of someone having some of these impairments with coordination and timing, again, compensation strategies are going to be seen with any attempted movement patterns, especially sport specific. And then we want to look at endurance of the pelvic floor. So again, going back to kind of what were those initial symptoms that the patient was sharing? Can they get through a race or a long run, or do their symptoms come on during that? Then that's going to be a little bit more indicative of endurance issues with that pelvic floor. And then finally, load related. So are symptoms showing up? Typically, symptoms are going to show up when demand exceeds capacity. So with running specific examples, we're going to think that volume and intensity increased recently. Yesterday was the first day of high school track. I can guarantee you over the course of this first week, this is probably more mileage than a lot of these athletes have been running if they haven't been doing some off-season work. So quick increases in intensity or volume are going to bring on some of these load-related symptoms. Downhill running, longer long runs, or heavy lifting blocks. A lot of runners I know, myself included, in the past, think hard days hard, easy days easy, meaning you do a hard workout, running workout in the morning and might be higher mileage, and then you go lift in the afternoon. When you think about the standpoint of your pelvic floor, that's a lot of load on the pelvic floor. And so for some of these patients, that might be worth addressing and talking about how do we modify your training because of the symptoms you're having, which we'll get to here in a second. So clinically, the strength checks out. You had the pelvic health therapist, colleague of yours, come help you with that. But the symptoms are occurring with some speed, fatigue, and impact. That's where you're going to want to focus on the coordination, endurance, and those load kind of buckets. So again, even though you're not a pelvic health therapist, potentially, depending on who you are tuning into this, we can still help coordinate diaphragm breathing. And it's not anything rocket science, but that coordinated breathing with that pelvic floor connection is very, I don't want to say easy, but I would encourage you to try it yourself and get it down, and then see if you can start incorporating it with your patients and your athletes. So screening and screening strategies to help identify, is this a pelvic floor issue? And if so, now what? So when we think about the true orthopedic lens, I'm going to guess this is not a common list of bullet points on your intake form or something that you often ask about, even if it's a hip patient, even if it's a low back patient. I would challenge you to normalize some of these symptoms and screening questions, because honestly, no matter the age, not many people are going to volunteer this unless they're strictly coming to the clinic to see a pelvic health therapist. Obviously, read the room, depending on the age of the patient, depending on comfort. If there's a guardian parent there, always good to have them in the room just so they can contribute. But again, most athletes are not going to offer this up unless you ask. So additionally, you want to ask about triggers. Run specific. Again, when do your symptoms come on? Do they come on with speed work, hills, jumping, or even just the cough, laugh, sneeze? And then screening. These are actual links, and I want to make sure anyone attending will get this presentation. But the links that I have attached here at the bottom, I highly recommend getting and keeping in your resource toolkit. So the National Association for Continence has a symptom diary that is just a really nice tool that if you have a patient who really just doesn't know, like, I don't know, I haven't really been paying that much attention, I just know it happens, this is a great tool for them to start tracking that. Um, and then additionally, a standardized screening tool is the PFD Sentinel screening tool, which I'll get into here in a second. It was research based. It was developed in 2022 and became readily available in 2023. So fairly recent. But that is a great tool, very quick and easy screen. So it stands for pelvic floor dysfunction screening tool in female athletes. So I will resort back to my comment earlier. It's a great tool for females. So in 2022, in this research study in 2023 that came out, these experts want to determine what symptoms, what risk factors, and clinical sports related characteristics are needed to be included for a screening tool. So this is currently the only sport specific screening tool there is for pelvic floor dysfunction. And it's aiming to promote that early recognition and management and figure out, okay, do we need to refer to a pelvic health therapist or not? So it's giving these athletes a more comprehensive and biopsychosocial care in order to be able to compete, but also thrive in their daily life. So this turned out a little more blurry than I wanted, but what's nice is those 5 symptoms, if one box is checked, then you want to refer them to a pelvic health therapist. The 28 items below that, if there are 14 or more, it's worth a conversation with the pelvic health therapist, and less than 14, keep kind of checking with the patient if things change over a couple weeks. But again, a very quick and easy option for the female athletes, backed by research. So I know this is not a postpartum specific topic today, but I think I'd be doing a disservice if we didn't at least touch on the guidelines that came out in 2019 for postpartum return to activity. Initially were very time specific. So, not wanting anyone, advising you not to run before 12 weeks and waiting until 3 to 6 months to really start progressing that load on the pelvic floor. But it is very highlighted that it's not it's individualized, it's not fixed. So the timeline should be person specific based on symptoms and not based on dates. But since then, so in addition, this also came out with the guidelines of a pre-running assessment. I actually really like this, and I use this even with athletes coming back from injury before we even talk about getting them in a return to run program. So this is ideal for postpartum and supported by the research to run through this gamut of kind of quick and easy tests. And if any symptoms pop up with the postpartum population, symptoms being leaking, pelvic pain, pressure, discomfort, any lower leg or lower extremity, then that would be a reason to hold off on progressing them into their running. This is a nice outline, and again, it's very time-based, and here's a visual of that. I do like this as a visual, and I encourage you to keep this or take a screenshot of this just for the sake of any postpartum patient you may come across, for the sake of not necessarily the weeks, but the actual examples of progression. Because when you think of getting back to running, like this entire topic today, it's progressive load. We don't want to just go from 0 to 100 on a trampoline that has been through a lot with growing a human and birthing a human. So I really like this as a resource. And then again, with that postpartum emphasis, you do have to consider asking some of the questions. How are you doing with sleep? Did you have a C-section? If you did, again, calling in maybe that colleague who knows a little bit more pelvic health related. How is that C-section doing? Are you breastfeeding? Because these are very important pieces to the patient that you have to zoom out and look at that entire patient and not just their injury or their symptoms. Again, same similar graphic from the guidelines in 2019, just as more of like a jump to conclusions map here of when you objectively screen these items, are you confident that they have passed those and can they start that return to run? As you'll notice, there are things on here more than just PT things. So again, that red S screen, I know it's blurry, but that is very important. We're not going to ideally throw a woman back into running if she's at risk of a bone stress injury because she has low energy availability. So that example there. So jumping ahead 7 years, the research that just came out, Emma Brockwell is actually a part of the research from the guidelines in 2019, was part of developing a decision aid for FIFA, for female soccer players overseas. And what they did was they wanted to develop a decision aid that actually looked at and took into account scientific literature of the research they've already done, the barriers that are keeping them from participation after birth, and helping create and refine objective decisions, but also looking at a full kind of health screen and not just the pelvic health. So these next few slides are the actual decision aid is what they call it. And there's 4 objectives. So I'm sorry, 4 slides for the flow chart. So as you can see on this first one, there's mental health, there's fear of movement, there's pelvic health. And it's such a interesting decision aid because it's taking into account so many different things within this female athlete. And I love it. And I plan to completely dive into this and utilize some of this for my own patients, even though they're not FIFA players. So contraindications for objective 2, asking some of those questions, where did they have a concussion? Do they have calf pain? Are they at risk of a blood clot? So definite contraindications that we want to be aware of. And again, the mental health piece, I can't preach enough, whether it's a postpartum mom or any female athlete for that matter. And additional questions again for pelvic health and additional considerations. And then at the bottom, objective 4, who is on your team? Who else is participating in this athlete's postpartum participation? So looking at the examples of a coach, a physical therapist, a pelvic health, a nutritionist or dietitian, looking at the entire athlete. And then this is kind of a nice stepping stone to look at in order to decide, do we move them up to stage 2 or 3? Do we need to take them back? And at the bottom, you'll see there the examples of specifics of what would cause you to say, yep, we're good to go, or no, we need to retrace. And then last thing, looking at in this developed decision aid is their intensity, and can they tick off some of these boxes before they move into moderate intensity, before they move into high intensity or other types of sport. So again, Emma Brockwell and the rest of her team developed this just very recently, and essentially it's to empower postpartum players and their multiple disciplinary teams in order to make that quality decision about that soccer play after having children. All right, so now how do we integrate some of these running specific load management strategies? So again, with the research, I might breeze through this a little bit here just because I want to have time for questions. But essentially, in this research, there was no difference between women with and without urinary incontinence with the half marathon pre and post, where they tested strength through the Perfect method, which is a internal pelvic health strength assessment. And then an additional study where they looked at women at running at different speeds. They actually did a vaginal probe. They did EMG stickies, and they found that running does trigger pre-activation of the pelvic floor right before heel strike, but then also after heel strike. So that tells us all the more reason we should incorporate some of the run training stimuli in addition to our basic pelvic floor training with our patients. With our training variables, we want to look at, again, some of those run specific things with how much are they running downhill? Do they overstride? What do they look like when they're doing speed work? And again, those double stress days of hard runs and lifting. We want to incorporate the breathing strategies, applying that breath work in single leg and closed kinetic chain exercises, not just lying on their back. And then obviously making sure they're not breath holding. So when we think of how we can modify this, we can encourage these athletes to change up. And this is where you're going to work with coach, you're going to work with athletic trainer, maybe a parent if it's a younger athlete, of how we can, modify some of these things that are definitely increasing load. Specific running variables that I have found very helpful, definitely cadence. When you think of higher cadence versus lower, a higher cadence means you're turning over quicker, you're in the air more than you're on the ground. When we're on the ground, we are impacting a lot more load into our pelvic floor. So any athlete that has a lower cadence than I would want, I'm going to help them retrain for some cadence retraining. And then again, uphill running. I love adding in uphill sprints after runs or within runs for patients, getting that posterior chain, and that does help with cadence as well. And then really trying to look at when are you doing speed work in your training, and emphasizing recovery as well. All right, so then, the cueing within our scope as PTs, obviously breathing. And if you want a great resource on incorporating what I'm talking about into running, I highly recommend Running on Air by Bud Coates regarding rhythmic breathing, which is you inhale for so many steps, you exhale for so many steps. It's something I started doing myself 11, 12 years ago and continue to do it still today. And I do think that has helped my own postpartum journey as far as what is going on with pelvic floor, teaching it how to engage, teaching it how to relax. So we want to reduce excessive bracing, obviously applying the diaphragm, breathing. We want to progressively load that return to running and basing it off of their symptoms. So I'm going to show you real quick. This is kind of just reiterating sometimes what we think of as core work is not necessarily functional core work. But this return to run progression also is developed from the guidelines in 2019 that I use with my postpartum runners, but I also use coming back from injury. So again, you'll see it's not on a timeline, it's on a phase. So once a patient can do 5 by 1 minute of running with 3 minute of walk, up to 10 minutes of total running, then we'll move to phase 2. So we don't do this every day. We allow a rest day. We watch symptoms. If you have symptoms during, after, or the next morning, we need to realign, reevaluate, refine. All right, so let's go back to that case I mentioned at the beginning. What did we change with this athlete? We modified her load. We modified how she's doing her run training. We incorporated her breathing strategies into non-weight bearing, then weight bearing, then sport specific. And we identified that she definitely was having some pelvic health issues early through our screening. So we referred her on. Outcome, she reduced her symptoms and her performance improved. All right, so lastly, some yellow and red flags to go ahead and definitely send that patient on to a specific pelvic health therapist. Let you guys read through those. And that again, I think if there's one screening resource that I recommend would be the PFD screening tool. If you have a pelvic health therapist in your area, in your own clinic, I highly recommend a co-treat session if that's feasible. I just think there's so much when you think of collaborative care within your own entity that can be helpful to learn from each other. Because again, a lot of pelvic health goes beyond the internal scary stuff if you're not a pelvic health therapist. But stepping back from that, zooming out even more, look at this list of people to have in your corner and making sure with your athletes, with your patients, that you're aware of these people and that you guys are all combining to make the best outcome for your patient as possible for better performance, fewer setbacks, and just an overall stronger athlete. So, key takeaways. Pelvic floor is a load-bearing structure. It's a dynamic and powerful dome. Those symptoms are often going to reflect a load mismatch due to that discoordination and the pressure. Strength of the pelvic floor is only one variable. So again, they can be strong, but a lot of times they are not coordinated. We need to be able to screen and refer when needed. And we need to make sure that we understand a pelvic floor dysfunction is a spectrum, and it's often going on before symptoms arise. And as anything with any orthopedic condition, not pelvic specific, the symptoms are that external layer. We have got to be clinicians who can peel back those layers to find that root cause, which is the deepest, often the deepest layer. I'm an office fan, so not that I left time, but if there's any questions, feel free to throw them out. And I'm sorry. Hope nobody fell asleep. Can you guys see the chat?
Yes.
I can't.
Oh,
Any
yeah.
any questions?
I don't see any in the chat currently. We would love it if you're willing to share your slides. We can get those sent out to our membership. That would be awesome.
Oh, there's the chat. Yes,
Did you
I
want-
will definitely.
Love that. Really appreciate that. And for everyone on here, we can get it sent out in an email afterwards. Lots of thank yous, great info. Really appreciated it. Did you get your chat pulled up so you could see too? But
I did, yeah. Finally got it.
wonderful.
Newbie.
No,
And
you're
I
good.
apologize a little bit long, but yeah, thanks you guys. And feel free to reach out. I think I left my email at the bottom on the last slide. So I will send that out. And then yeah, anybody has any questions, they can reach out to me.
That sounds great. Thank you again, Dana. Appreciate your
Yes.
expertise and thank you for sharing.
Yeah, you're welcome. Thanks, guys.
Uh, all right.
Thank you.
Well, for everyone still on here, we are going to go ahead and have our meeting tonight at 7 o'clock. We'll give everyone, it looks like it's about 3 till. So if you need to grab something to drink, take a quick bathroom break, we will start the meeting here in about 3 minutes. So grab whatever you need and come on back for the meeting.
All right, I'm gonna bounce. I'm gonna go to a Norwalk basketball game. Hopefully they qualify for
Good luck.
state.
Good luck.
Okay, thanks. And then do you want me to email? Did you say to you?
If you've already been emailing with Alec, you can email them to him and then we can get them to Kayla and we'll get them sent out. So
Perfect.
whatever's
Okay.
easiest is
Okay.
perfect.
All right.
Perfect.
I'll do
Thank
that.
you.
Thanks. Thanks, Alec.
Thank you, Dana. Yeah, thank
Okay.
you.
See ya.